Okay, good evening. Welcome to the 13th session, I think this is. And it's basically a continuation of the last time's managing labor, right? So today we are going to concentrate on CTG. So I got my senior registrar to send me a few CTGs. So we will. So today will be a relatively short session, and the CTGs I will just analyze with you all once I have just discussed everything. So number one, the interpretation of CTG comes under a very broad categorization or category or the principle of fetal monitoring in labor. Okay, so few things that we need to understand. So in labor, there are broadly two categories, right, which are very commonly used. One is the pinard or auscultation by the pinard stethoscope, and the second one is the cardiotocography. There are other modalities like fetal ECG, computerized CTG, all these. However, these are not commonly available, and usually they are available in a research setting, and therefore we do not normally use those. So you need to be aware of these two modalities as MBBS students and as interns as to how to monitor the fetus during labor, right? Basically, that is one. Number two, if the fetal monitoring, and if we are not really sure as to how to proceed, if we think that she needs delivery, but still then we want to make sure or we need to take a decision, then the next step in all this is fetal blood sampling, right? It's basically a small speculum-like instrument is put in the vagina, where so the baby's head is visible, and then a small nick is made on the fetal scalp, and a small tube is put or touched where the blood comes into that tube, and that is sent for to measure the pH of the blood or the lactate, one or the other. We don't need to do both, but commonly we measure the pH. So that is done when the CTG is deemed pathological, and then still we are not sure whether to deliver or not. In that case, fetal blood sampling can give us an indication as to whether we need to deliver. Fetal blood sampling is not commonly available in Sri Lanka, but in most countries, in countries where the facilities are available, it is something that we do when we have a pathological CTG and still we think that she can deliver vaginally. So to make that decision whether we need to deliver immediately or to go on and allow her into labor or let the labor go on, we can do a fetal blood sampling. So if we get a pH of less than 7.2, then definitely you need to deliver because it is not normal. Anything between 7.21 and 7.24 of pH, then we can still wait because it is not, we don't need to immediately deliver. So it's a borderline sort of reading, and anything over 7.25, then that is considered normal. So even if we have a pathological CTG and still without any other indications for delivery, because we need to consider everything, every factor, not a single factor, everything by itself, then of course, if the fetal blood sample, if the pH comes over 7.25, we don't need to deliver. So therefore, remember, all these are not individual single things that we are going to rely on to make a decision. It's a complete clinical picture. How long she has been in labor, whether there are any other factors that compromises her, whether there is meconium stain, whether she is having bleeding, whether there are any other medical problems that we need to consider, right? We need to consider the woman's wishes as to what she wants. So, and taking all that consideration and putting in the fetal monitoring part, which may be a CTG, and then of course we can include fetal blood sampling if the CTG is practical and we are done it. So taking the whole picture into consideration, you make a decision whether to deliver or not. So remember, everything is not absolutely clear cut. So those are all clinical decisions made along the timing of labor, right? So that is what we have to remember. So putting fetal blood sampling aside, because that is all you need to know, let us concentrate on two things. One thing is measurement or checking the fetal heart sounds by pinna stethoscope, and then we go on to CTG. When do we use the intermittent auscultation by pinna? When it's a low risk woman without any problems at all, right? And then we can use the pinna stethoscope, usually once every 15 minutes or so, which is done after the contraction, and the fetal heartbeat is listened to for 1 minute. Okay, it can be done frequently when the labor progresses, but usually 1 minute, remember that, after a contraction every 15 minutes or so, right? So 4 times out. So there you count for 1 minute, and then if there is any suspicion there, so if you feel a bradycardia or a tachycardia or feel there's a problem, then of course you can switch on to electronic fetal monitoring or cardiotography at that instance, right? So, but usually we employ intermittent auscultation, and remember, for low risk labors where everything seems to be going well, there are no problems. If we are not using oxytocin, she has gone into spontaneous labor and it is not an induction, right? So, and therefore, if the amniotic fluid is clear, there is no meconium or blood there, right? And there is no signs of obstruction, then of course, intermittent auscultation is indicated, and electronic fetal monitoring is not indicated. However, anything else, that is, if you are using oxytocin, if she has gestational diabetes, if you have pregnancy-induced hypertension, any type of, if she's on any type of medication, if there are any other medical problems complicating the pregnancy, if the labor is dystocia, if it is not progressing well, if there are signs of obstruction, or anything that varies from the normal, then we switch on to continuous electronic fetal monitoring. It's different from sometimes what we have in our labor rooms, because continuous electronic fetal monitoring means, one, the woman is put on a monitor, and all the time, if she's in labor for 10 hours or 8 hours or 6 hours, the whole trace is recorded, right? And it becomes quite large sometimes. So it just folds, and it sort of becomes like a big book, and which can be unfolded, and it becomes a very, very, very long strip, right? So that is what we have to understand, right? By continuous electronic fetal monitoring with recording, right? It's not something what normally we do, because CTG is in Sri Lanka, and CTG paper is expensive, right? And therefore, we will take a tracing when it is deemed necessary and if there's a problem. But usually, what it actually means is, if we are going to do continuous electronic fetal monitoring, we will have the complete record, all the number of hours that she is in labor and connected to the machine, right? Okay, so that is an overall view. The next thing we have to understand is the principle behind this. What is the principle? The principle is, we are using sound or ultrasound, right? And what is ultrasound? Ultrasound is the frequency of the sound wave is higher than what we normally hear. Our normal hearing age is from 20 to 20,000 hertz, right? Which we all know. Anything above that is ultrasound. So here, what is being used is megahertz, right? So they're very, very high frequency sound. So how does this work? It works on the Doppler principle, right? And what is Doppler? Doppler basically means if you send from one point, if you send an ultrasound beam down to some structure, in this case, in a CTG, it's the heart valves that are moving up and down, right? So what is moving in the heart? Not the whole heart actually. It moves a bit, but the thing that moves most in the fetal heart is the heart valves, right? So what happens is when the probe which we place on the woman's abdomen emits a signal, an ultrasound, right, which is high frequency, it goes down, hits a valve, and is transmitted back, right? Then what happens is the next wave, now say the heart valve is like that, it hits and comes back, and the probe detects that. Next time it continues emitting ultrasound, but the valve has gone down. So therefore, when this ultrasound wave comes, it has to go further to hit the valve, and then it has to come back. So the time that it hits when the valve is here is less than the time that the ultrasound takes to return if the valve is here. So there's always a difference between these two times that the ultrasound needs to travel to hit the valve, because the valve is moving up and down, right? So this time difference, if measured, is something that we call the Doppler effect. For example, we also perceive that Doppler effect. For example, if there's a siren or an ambulance coming towards us, we hear the sound, but see, every time it moves closer, it takes less time for the sound to reach our ears. When it moves closer, it takes less time. So therefore, in our brain, we know that this sound is approaching us because we are calculating the differences and the amplitude and the strength of that signal in our brain. And when it goes away from us, we know that it is going further and further away, although the sound emitted by the ambulance is the same, right? So it's the same thing. The machine calculates a difference, right? And it can detect by its computer where the valve is. So remember, to complete one cycle or one heartbeat, the valve needs to go down and up, down and up. So basically the ultrasound machine or the computer understands when one heartbeat has happened. Okay, what it does is it calculates, okay, now the machine knows, okay, one heartbeat has gone. Then again, it calculates the next heartbeat. Okay, it calculates next heartbeat. So the computer can detect the heartbeats, and therefore the computer can detect the distance or the time taken between two heartbeats, right? So if the time taken between these two heartbeats, shall we say, is 0.5 seconds, the computer will automatically calculate and tell us, okay, at this point, if it goes on like this, the heart is going to beat 120 times per minute, because the time between two beats is 0.5 seconds. You all understand? So therefore, what it does is, it immediately calculates this and puts it on the machine. That is why we see 120 there. Then again, it calculates the distance between two heartbeats and calculates, okay, the amount of seconds, divides it by 60 quickly and says, okay, 132. So it puts it on the machine. So that is why we see a different value each time. 120, 131, 120, 140, 131. So we see a different value. Okay. Now imagine if you want to record it, right? If the paper is not moving, right? What's going to happen is a dot will be put on 120, and if the next one is 130, another dot will be put on 130. If the dot is 115, and the dot will be put on 150. So we are going to have all the dots in one straight line. You all understand? But since the paper is moving, what happens is these dots will be put on different times at the paper. 115, 120, 130, 120. So if you connect those dots, you get a graph. You all understand? So that is how we get a graphical representation of the heartbeat, which is called the cardio part of the CTG. Is that clear, children? Right? So the paper is heat sensitive, and the tip of the machine of which strikes is heated. So it puts a dot on 120, the machine calculates 131, the paper is moving. So then again it puts 130. So it goes along the paper, 120, 130, 120. So it sort of draws the whole CTG for you. You all understand? So that is what we analyze. So that is number one, which you need to understand, right? So now all this thing is based on emission of ultrasound, and it's the ability of the probe to detect it. Now this emission of ultrasound is done by a certain type of crystals, which are called piezo ceramic crystals, right? Which are special crystals. And what happens is, when these crystals have electric current between those, these ceramic special crystals can expand, and then when the current is out, it comes back to its normal. Depending on the voltage and the frequency, it can do this. Okay, so it compresses the air in front of it. And what happens? Compression, decompression, compression. So it creates a ultrasound beam. Got it? So that is why this ultrasound probe has piezoceramic crystals which generates ultrasound, and at the same time it has ways of detecting the ultrasound that bounces back, right? So the most expensive part of the whole machine is the probe. Right, children? It's not the computer, it is not the digital display, right? It's nothing but the probe. So please, as the house officers, as we will take good care of the probe. Is that clear? In it, there's another probe, which is called the TOCO, right? And that does not have crystals in it, and that does not emit ultrasound. So therefore, that is the one that is pressure sensitive. So each time the uterus rises up with the contraction, it's kept on the tube. That side is pressure sensitive. So it detects the amount of pressure, and it graphically represents the contraction. So when we start the trace, we make the pressure 0. And depending on that, when the contractions occur, it will give us something like, say, 100% or 50%. So it will give us a relative sort of graph saying what type of contraction it is. Okay. Next thing you have to remember is that the paper moves at a very set speed. So usually we can change it, but normally we can make it move at 1 centimeter per hour, 2 centimeters, sorry, 1 centimeter per minute, 2 centimeters per minute, or 3 centimeters per minute. Our standard and the lowest, because that expends the lowest amount of paper, as you can understand, we normally set the machine form to move, or the paper to move at 1 centimeter per minute, right? So in the whole cardiotocograph, if we take 1 centimeter, right, that represents 1 minute. Well, understand? So usually the 1 centimeter is divided into 2 boxes, right? So 2 of these boxes or 2 squares will represent 1 minute. And for 1 minute, the paper will move along that 1 centimeter. Okay. So So basically the CTG has the upper part, which gives us the cardio tracing, right? Which will have annotations up to about 200, 220 from about 60 or 40 to 20. And then the lower part is the toco part or the contractions, which will give us 100, say 0 to 100%, or there may be millimeters per mercury can be recorded as well, but this doesn't matter. So you need to zero the contraction initially, and relative to that, it will form the graph. So whatever happens, it happens with time because the paper is moving. Also, so you can measure the how long something took place. For example, if it's an acceleration, okay, for how long it took place, because the paper is moving. If it has occupied 2 squares, that means the acceleration has happened for 1 minute. If a deceleration happens and if it has moved for 4 squares, we know that it has happened for 2 minutes. For the contractions also is the same. If the beginning of the contraction to the end of the contraction, if there are 4 squares, which means the contraction has gone for 4 minutes. Do you all understand? So that is how we calculate the duration of each phenomenon. That is, whether it is an acceleration, deceleration, or whether it is a non-reactive trace, or whether how long the contractions go on. All these can be checked because the paper is moving at a very fixed rate. So that is the basic principle that you need to understand about cardiotocography, right? Any questions so far? I'll quickly take questions. I have taught you now the basis of cardiotocography, okay, and the physics behind it to a certain extent. Is that clear? Right? Any questions you want to ask me? I'll take quickly a few questions if you all have questions. No? Everything understood? Okay. So you all are very, very bright. I'm so impressed even at this time. Okay. I'm so happy to be teaching all this. Right. So let me spotlight. Okay, right. So let's move on to the next part, right? Now the next part is well, finally I have a question. If the 2 photos being changed, if the 2 probes being changed, the placement, what would happen? Don't change the placement, right? Now, it's like this. The toco probe is usually kept at the place where the uterine contractions are generated. Normally, the uterine contractions are generated at the top or the fundus of the uterus towards the conua, one of the conua. So there is where you need to keep the toco. The cardio probe needs to be kept where you hear the fetal heart sounds best, right? And how do you do that? Initially, you check for the position of the baby, which I have taught you. Find out where the baby's shoulders are, and then you do an auscultation with the pinna to make sure that it is where you can hear the fetal heart sounds well, and then you place the probe. Remember, for the toco probe, gel between the probe and the abdomen is not necessary because the toco does not work with ultrasound. It works with the pressure difference. There's a membrane there that calculates or is sensitive to pressure, and therefore it can be just placed on the abdomen. While a lot of ultrasound will be lost between the probe and the abdomen if it moves, because with contraction obviously means, and when air comes in between the probe and the abdomen, a lot of ultrasound will be splayed out, will go out, and therefore it is essential that you put gel, ultrasonic gel, ultrasound conducting gel between the probe and the abdomen before you place it on. Remember, please don't use the most expensive part of the machine, right? So don't do this and do this. Okay, what happens? You will hit by mistake, you will hit the probe and it will damage it. Okay, so please place the gel in the appropriate place on the abdomen and then only place the probe there. Okay, so that is how you need to take care of the machine. Please wipe it every time you complete it. And the next question is, can we tell the strength of the contraction by the amplitude of the top? Yeah, so that is, we always get not a very good measurement. What we do get is a relative measurement. So if it goes to 100%, we are looking at a very good contraction. If it just goes to about 30-40%. So it's relatively, it is 100 bars millimeters mercury per minute. That is how it's measured. But that is not an exact representation for the amount of power generated. We really need a relative 0 to 100 sort of percent between the TOCO. So that is how we analyze the TOCO. What is important in measuring the contractions and the trace at the same time is we are on the lookout to find out how the baby's heartbeat changes with the contractions, and depending on that we classify the decelerations, which I'm going to tell you later. Okay, so that is the most important thing, because we record the heartbeat with the contraction simultaneously, and we can watch and say how the heartbeat changes with the contractions, which is very important when you look at the decelerations. I will teach you all at a later stage. Is that clear now? Right. Next is what you have to understand now is, now since we understand the principles, the complete whole exercise, what you have to understand is that CTG does not have 100% sensitivity and does not have 100% specificity. What does that mean? It means that there is no way of monitoring the fetus 100%, right? So if the CTG has a problem, right? So if it shows us a problem, that does not mean roughly 50-50%. So if we have a bad CTG, that does not mean 50% of the time that the fetus is bad. If we have a very good CTG, and that roughly does not mean that 50% of the time the baby might be having problems. You understand? So if the CTG is completely normal, right, still the baby can have problems. So that is why CTG must not be considered alone and as the sole indicator of fetal well-being. You need to use your clinical judgment, the patient's preferences, and everything in between, and look at all the clinical aspects of it, right? And then decide on what is good and whether you need to deliver the baby or not, right? I have a question. In a woman who is not in labor, do we have a place for the TOCO always? Right. Now we are talking about an antenatal CTG, which is not the discussion. It's not the discussion point, because we are talking about women in labor. Yes, the TOCO must be placed if you are going to do an antenatal CTG, because number one, the Braxton Hicks contractions will be recorded, and the woman may not be feeling the pain, but and at the same time, it might show us problems in the antenatal time if even with the mildest contractions, if the baby's heartbeat is coming down or is showing decelerations in the antenatal period, that definitely is not normal. Okay. So if we just do antenatal, it's a lot of controversy as to whether you need to do an antenatal or pre-labor CTG or an admission CTG as is called, right? Because its sensitivity and specificity is very, very small. That means that its ability to detect a problem is small. But however, if we do it and we find even with the slightest Braxton Hicks contractions, right, which the woman does not feel the pain, but it's contracting and it is recorded in the machine, and you're still getting decelerations with that, then there is some big problem there. We deliver, right? So it is not normal for us to have decelerations in an antenatal CTG, and more so if it is connected with the contractions, and therefore it is essential, if you are going to do a CTG, to do a complete CTG by putting on both probes. Okay, right. So that is beside the question. So let's go back to our original discussion. Now, all the intention, our intention, or the house officer's intention, or whoever is monitoring the labor, the intention is to classify the CTG into 3 large categories. Okay, we need to classify the CTG, and you need to have the ability to say whether the CTG is normal, suspicious, or pathological, right? So the whole intention of doing a CTG for monitoring in labor, right, is to say, as a house officer, right, or as anybody who's monitoring, if a senior calls, you should be able to tell the senior, this CTG is normal, or this CTG is suspicious, or this CTG is pathological. Because each of these classified entities will have different types of management. If it is normal, remember, we can continue the monitoring and we don't need to go back to that again. If it is suspicious, then we have to do certain things to make it better, right? Which may be, we might need to hydrate the woman because dehydration can cause reduction in placental perfusion. We may need to change the position of the woman so that the CTG might improve, right? We might need to do certain tests by fetal scalp stimulation, right? By vaginal examination, and that might improve the CTG because that stimulates the fetus, right? We might need to reduce or stop the oxytocin and see whether the CTG improves, right? So these are interventions that you might want to do if the CTG is suspicious. If the CTG is pathological, right, normally the intervention would be to deliver. So if she's fully dilated, maybe we might decide on doing an instrumental delivery. If it's not fully dilated, but it's almost near delivery, then the decision is, is it possible to wait another 1 hour or so for her to deliver, or do we have to deliver immediately? In doubt, if there is no fetal blood sampling at that point, then of course with the pathological CTG, we will have to deliver. If we have fetal blood sampling at that point, we can do a fetal blood sampling and then decide whether we can wait on it. And you can repeat the fetal blood sampling and at certain intervals. You all understand the usefulness of fetal blood sampling, right? So say if the CTG is pathological, or says 9 centimeters, right? And we are waiting for her to do a spontaneous delivery, right? And then when we have a pathological CTG for 30 minutes or more, that is why it's called pathological, right? Or say deceleration for 30 minutes, or a pathological CTG, then to take a decision, you will need to do a fetal blood sampling. And if the fetal blood sampling comes as 7.19, which is less than 7.2, then of course you deliver, you don't wait. If the fetal blood sampling comes at 7.25 or 7.26, it's normal. So I think we can wait without a problem. If it comes between 7.21 and 7.24, that is the gray area where you might need to either you can wait or you can repeat the fetal blood sampling in a certain amount of time in 20-30 minutes to see whether it is changing and then decide for a delivery. Do you all understand? Of course, there are certain instances in the fetal CTG where you should not be wasting your time doing fetal blood sampling, right? Such as if there's a prolonged deceleration continuing for more than 3 minutes, or an acute bradycardia, the heart rate is gone, and if you waste time doing it, the baby will die. So therefore, it is important for you to remember that there are certain instances during a pathological CTG where you might need to, you cannot do fetal blood sampling, you directly go for delivery, whichever way or the shortest way that is possible. Either it can be an instrumental delivery or it can be a forceps, that is a vacuum delivery or a forceps delivery, right? So having Now we have done the overall overview, which you all have to understand. So now the next step is to actually analyze the CTG. So to give a summary, children, right? I have told you about the physics. I have told you how the probe works. I have told you there are two probes. I have told you about piezoceramic crystals, right? I have told you how the CTG machine works, right? And how it puts those displays on, right? And I have told you that what the principles are about the CTG. Next, I have said when to use it, when to use intermittent and when not to use intermittent and continuous CTG. And then I have told you that as people who are monitoring, right, the frontliners in the labor room, which is usually a house officer, the aim is to classify the CTG into three types: normal, suspicious, or pathological. And I have told you now what you should do for each of these types of traces which you will find. Is that clear? Right. Then comes our understanding, or the next step is how to classify the CTG. And therefore, for this, we need to consider 4 features of CTG which you need to understand, right? And what are these 4 features? Number 1 is the baseline. Number 2 is the baseline variability. Number 3 is the presence of accelerations. And number 4, the presence of decelerations, right? So in the trace that we are given, remember, we needed to identify each of these and find out exactly what has happened with each of these 4 features. Okay, so let's start from the baseline. Okay, now what does the baseline mean? In a normal fetal heart, right, the heart rate is dependent on mainly on 2 main nerve compartments. What are these? The sympathetic and the parasympathetic, right? The sympathetic will increase the heart rate and the parasympathetic will decrease the heart rate. Okay, so it's always this influence depending on the body's condition, what it requires, what triggers it off. The sympathetic and the parasympathetic will continue to increase and decrease. So it is never totally, it is never a same heart rate in any person, whether it is adult or a baby, right? Because what happens is, if there is a problem and if the baby is hypoxic, okay, then, and the heart is hypoxic, what happens is the heart stops listening to the sympathetic and the parasympathetic. It just beats on its own. In the sense, what it does is doc, 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 same amount. The sympathetic is saying, okay, increase the heart rate. It doesn't listen. The parasympathetic say, okay, decrease. It doesn't listen. Intrinsically, it goes into its own pace. When there's a problem, people do like this now. They withdraw. Doesn't listen to anyone, right? So what happens? When that happens, so you have a very, very same heart rate if there's no acute problem. So you get what? 120 or say 105, 105, 105, 105, 105, 105, right? When the machine calculates the time in between and then puts it on table and puts a dot. So what do we get? We get a straight line. I'm actually talking about variability now, but we'll get back to that. I just wanted you to understand what it means. So let's get to baseline. So usually what happens is, what I want to tell you is, the baseline is the frequency of the heart in between 2 phenomena. Okay, it might be between 2 accelerations or it will be between 2 decelerations. So if you look at that, If you are looking at the heart rate in between two accelerations or decelerations, that is what we call the baseline. Now the baseline will never be one line because there will be accelerations. It will go on like this. So what you do is you choose a part of the CTG between these two accelerations and draw a line in between the peaks and the troughs of the variable. And therefore you will get the baseline at that point. You all understand, right? So I will show it to you. So that is how we get the baseline. So depending on the baseline, then we have to find out whether it is normal, right, or not. So the baseline, children, depending on the amount or the number which we find, the baseline is defined. All these features are divided into three groups. The first group is called reassuring. We are happy. Okay. The second group is called non-reassuring. Okay. And the third group is called abnormal. So what you have to do basically is to get each feature of the CTG. Remember, I told you 4 features. We have baseline, we have baseline variability, and we have accelerations and decelerations, right? So you take each of these, identify it, and then put it into 3 categories: reassuring, non-reassuring, and abnormal. Okay, so you put the features into those 3 categories. I will tell you how it finally sort of sums up into our classification of normal, suspicious, and pathological. That comes later. Okay, so now once we have calculated the baseline, let's think of what is normal and not. So what is reassuring is if the baseline is between 110 and 160. Okay. What is not reassuring is if the baseline is between 161 and 180, and if the baseline is between 101 and 110. Is that clear? So reassuring is between 110 and 160. Non-reassuring is between 101 and 110, and between 161 and 180. Right? We had different types of classifications earlier, but this is what we are going on now. I'm quoting the NICE guidelines, which was revalidated again in 2017. So go to the guideline, it's intrapartum monitoring, fetal monitoring, and you will see all this. So you can just, today I'm not going to give you, because it's a lot of information. What I want you to give is a very overall understanding, and I want you to go later to the NICE guidelines and look at 2 tables, which will summarize everything for you. So get it into your heads now as to what it is, and then you can look at the specifics and study them, which should be easy for you. Okay. So we classify the heart rate or the baseline of the heart rate into 3 again. If it is anything below 100, again, it is abnormal. Okay. And then from 101 to 110, it is non-reassuring. And if it is from 110 to 160, it is reassuring. Again, from 161 to 180, it is non-reassuring. And from 180 onwards again, which is called tachycardia, right? It is abnormal. You all understand now? So what you have to do is to get the trace, find out 2 phenomena, which is acceleration or decelerations, and then find that bit, draw a line in between the uppermost and the lowermost ones, right? In between somewhere, and then check from the CTG as to what the baseline is. Got it? That is number 1. The next thing is we'll take accelerations. Now, accelerations is interesting because a definition of an acceleration is that the heart rate goes above the baseline, right, for more than 15 beats. I will teach you how to calculate the amount of beats for more than 15 beats, right? And goes on for more than 15 seconds. It's an acceleration. Okay, I will show you how that 15 seconds is found out, right? So an acceleration, anything that goes above the baseline for 15 beats and continues for more than 15 seconds is an acceleration, right? So accelerations can be big or can be the minimum amount, but then still it's an accelerator. It is thought to be like a small child who is healthy, because if the child is healthy, what does it do? If it's on the playground, it will jump up and down. Of course, there are some adults also who do that, but if you put a child on the playground, then if it is jumping up and down, right? And of course, you see monkeys do that. You've seen the healthy monkeys jumping up and down, right? So those also. So you see, that shows that it's like, that is the way it is sort of thought of an acceleration, because it's only a healthy baby's heart that shows intermittent accelerations, right? So if you see that, you need to be happy that the baby stopped. So even if the CTG other problems are there, still if there are accelerations, then you need to understand there might be that the baby is doing well. Okay, so it is a sign of good health if you see it. However, absence of accelerations does not always mean there's a problem. However, the presence of accelerations is a very, very good sign. Right, I have a question. Can you repeat about accelerations, right? An acceleration is something, so say you have a baseline like this, and suddenly the heart rate goes up and the trace is up, and then it comes down. So if from the baseline, if the heart rate goes up more than 15 beats, say the baseline is 120, 30, and suddenly it goes to 150, that is about 20 up, and then it continues for half a minute, that is more than 15 seconds, then it is an acceleration. You all understand? So we call that an acceleration. So its presence means it seems to be a healthy baby. It's only a healthy baby heart which will have acceleration. So you can have many or more accelerations which you can find, right? And sometimes during a movement also you can feel the accelerations, right? So when the baby is moving, the heart also accelerates. Okay, so it is a healthy sign. So that is the second sign. Remember, the presence is always good. Absence does not always mean there's a problem. Okay, so therefore accelerations are, or their absence are not classified or put into our classification or trying to classify the CTG. Is that clear? Next part is baseline variability. Okay, so now we are done with the baseline. We are done with the accelerations, and now we have come to the baseline variability. What does that mean? Remember, as I told you, right, a healthy baby's heart or an adult's heart is always, it reacts to the environment around it, right? And therefore, it is never a constant heart rate. It always changes. It only goes up and goes down, because it's the sympathetic and the parasympathetic that is pulling it this way and that way, and that is why it reacts to these nerve impulses to change its heart rate. So therefore, the healthy heart always have a variability. How is it calculated? You take the best variable portion. So we like good news, right? We don't want to be pessimistic, where you get the lowest portion and then calculate variability and say be unhappy. You know, there are some people like that, of course, who would love to look at the most depressing part and represent that as their life. But on the other side, there are happy parts as well. Okay. So when you take the baseline, take the part with the healthiest or the biggest variability. Okay, and then from there you calculate the baseline variability. What does that mean? The distance or the number of beats between the highest and the lowest peak in the baseline, right? You can't do it in an acceleration. In the baseline is the baseline variability. So how do you do it? We check the part where it has the biggest variability, take 1 minute of the trace, draw a line on top where the highest peak is, draw a line on the bottom where the lowest peak is, and then calculate the number of beats in between. And then you talk about the baseline variability. Is that clear? And the norm is between 5 and 25. The normal is between 5 and 25. Less than 5, the variability is low. Over 25, the baseline is also not normal. Okay, and we call it abnormal. Okay, so non-reassuring is less than 5, right? That can be classified later, which I will tell you. While abnormal, right, is over 25. Between 5 and 25 is considered normal. Is that clear? Right? So, how do we, later we will speak about. Now, how do we classify this baseline variability into, because we need to look at 3 parts now. We need to talk about it being reassuring. We have to talk about it being non-reassuring, and we have to say when it is abnormal. And then you need to put that into the classification as well. Give me one moment, sorry. Okay, where were we? Yes, Namal, where were we? Sorry.
Baseline variability.
Variability.
All right.
Classification.
Okay. Baseline variability, right. So, did you all understand what baseline variability is? So now we need to look at it and put it into our 3 types: reassuring, non-reassuring, and abnormal. Reassuring means it is between 5 and 25. Is that clear? Right. Non-reassuring means if the baseline variability is less than 5 and continues for 30 to 50 minutes. Okay. So if it continues for 30 to 50 minutes, then of course we are looking at a non-reassuring phase. Or if it is more than 25, which is wild, goes up and down, right? If it continues for more from about 15 to 25 minutes, okay, which is more than 25, then it becomes non-reassuring. All these I don't need to say, they are all in the nice guideline. I just want you all to understand, right? And what is abnormal? Abnormal is if the baseline variability is less than 5 and continues for more than 50 minutes. Okay. Or if the baseline variability is more than 25 and continues for more than 25 minutes. Okay. Is abnormal. Got it, children? Right? And there's another pattern that comes into the baseline variability part, is the pattern which you call sinusoidal. What is sinusoidal? There is no, it's like a wave, sinus wave on Nohoma. Right? It's like this. So it increases, decreases, but it goes like this. So it's a sinusoidal pattern, right? So then you call it the baseline is, baseline you can calculate by drawing a line and say this, but the baseline variability, we call it sinusoid. If there's a sinusoidal pattern, then that becomes definitely an abnormal CTG. Okay, abnormal, the characteristic or the feature becomes abnormal. Is that clear? Right. So therefore now we have also classified what? The baseline variability. So we have done accelerations, we have done the baseline, and we have done the baseline variability. Is that clear? Any questions there? Quickly type in or ask the questions. What is the difference between non-reassuring and abnormal? Right. So remember, children, what the exercise of what we are trying to do Remember, we have 4 features of a CTG: acceleration, deceleration, baseline, variability. Each of these features we categorize or classify into 3 groups, which is called reassuring, which is we are feeling good. We call them non-reassuring, and then we call them non-reassuring means it is not normal, but it is not 100% abnormal. It is something in between, right? And then we call next one, we call a certain type abnormal. So these are the 3 things that we classify. This classification is required for us, or this differentiation into reassuring, non-reassuring, and abnormal is required for us to classify the CTG, right? So I will let's get to, because you will understanding it better now. What is a normal CTG, right? Normal CTG is when all 3 features of the CTG is reassuring, right? Or even all 4 features, that is the presence of accelerations with a normal baseline, a reassuring baseline variability, with a reassuring baseline, and with the absence of decelerations, right? All this becomes a normal CTG. Okay, what is a suspicious CTG? When 2 features are reassuring and 1 feature is non-reassuring, and that is a suspicious CTG, where you will need to do certain things: change the position, hydrate, stop the oxytocin to make sure that it looks, it becomes better. And what is a pathological CTG? Is when there is 1 abnormal feature, right? Or when there are 2 non-reassuring features, or a combination of any, right? And that is the minimum that is required to call it pathological. You all understand? So therefore we classify the CTG looking at these features which we have already divided into 3 groups, and then you look at them and then you classify into normal, suspicious, and pathological. You all understand? Only on that classification we will take certain actions. Normal CTG, we don't need to take any action. Suspicious CTG, do things to try and improve it. Usually it is turn in the mother side, hydrate in the mother, right? Fetal scalp stimulation, right? To see whether it changes. Then stop the oxytocin to see whether there are any contractions. Check whether there is cord compression, right? Or there are any factors that are, check whether there is meconium, bleeding, do a vaginal examination, check whether there is obstructed labor. So all that we need to check and find out, right? Pathological CTG, of course, you have to deliver. If you want to delay the delivery, you will need to do fetal blood sampling appropriately, not all the time, right? You all understand? So that is where we have to go to, but now we have to try and classify the features, right, of this into these 3 categories. Is that clear? I hope the questions I have. What is the difference between non-reassuring and abnormal, which I have done? So it's just a way of classifying. Is sinusoidal pattern a trouble in a variability? No, it's not a trouble in a variability. It is a fetal state which we do not exactly understand why it comes. Even thumb sucking is supposed to cause a sinusoidal pattern. Sinusoidal pattern, but it can change. So therefore, we do not know, but it is not reassuring, it's abnormal. How to classify the accelerations as reassuring? We do not classify accelerations as reassuring, non-reassuring, or abnormal. All accelerations are reassuring. Okay, so their presence is good. Absence does not come into the classification, right? If it is there, you are going to feel happy, children. Okay, happy face, right? Can you please explain how the baseline variability measure once again, please? I will show it to you all, please, children, right? How do you measure baseline variabilities? You take 1 minute of the strip. So if the trace is going at 1 centimeter per minute, you have to choose 1 minute. How is 1 minute represented? In two squares. There are two long lines, and in between there is a small light line. So 2 squares is 1 minute. So you take the best variable place, choose 1 minute, draw a line at the top where it has reached the peak and the lowest, and then find out how many beats are in between. So that is how you measure baseline weight. I'll show it to you, children, don't worry. Please explain what is normal, suspicion, pathology, CTG again. Okay, I think I answered that question, right? Okay, so that we will get back later. The whole point is now, remember, to get each of these features, right, and put them into reassuring, non-reassuring, and abnormal. And then looking at all those, you classify the CTG. And again, if I tell you, if you want to hear it again, which I will do, a normal CTG is when every feature, right, which is baseline variability, and absence of decelerations, right, all these features and the presence of accelerations are reassured. Okay, right. The suspicious one would be when there is one non-reassuring while the two other features are reassuring. Pathological would mean there is one abnormal feature, at least one abnormal feature, or if there are two non-reassuring features. For example, if the baseline variability is 105, right? If the baseline variability is 3, okay, right? And if the baseline is 105, we have two non-reassuring features. We call that pathological as well. You all understand? So to get to that, we have to be able to classify or check the features again. We'll get to that. So let's get on to one of the most important parts is what? Decelerations. Okay, is that clear? Shall we move on? Yeah, okay. Right. So the next part is deceleration. So what we are going to do is I'm going to explain to you what decelerations mean. In a classification, deceleration means what? If the heart rate drops more than 15 beats below the baseline and continues for more than 15 seconds, it is called a deceleration. Okay, so it can drop more and it can run, so but that is what is called a deceleration. And how does that happen? When the baby becomes hypoxic for some reason, and then therefore the heart rate starts to fall, right? However, when it falls again, right, the baby's parasympathetic is initially stimulated, so therefore the heart rate drops. But however, then the sympathetic kicks in and the heart rate goes back to normal. So it forms a deceleration, but that is, it returns back to its normal sort of state. So there can be 3 different types of decelerations, right? And these are classified solely on the fact of with their relationship to the contraction of the uterus, right? And that is why they are classified as early, late, and variable. The rest of those classifications about typical, atypical, all these are out. Okay, and how they are classified? They are classified as early decelerations, late decelerations, and they are classified as variable decelerations. And there's another one which is called prolonged deceleration as well, which is the deceleration that continues for more than 3 minutes, which has a special category where we need to deliver immediately. Okay, so that category will take it off. What we need to look at is 3 types of decelerations: early, late, and variable. What does early mean? Early means the contraction starts and the deceleration also starts early with the contraction. When the contraction is at the peak, the deceleration is also at the lowest. And when contraction starts to wear off, the deceleration all slowly recovers. So it mirrors the contraction, and that is why it's called early. Starts early, ends early. Okay, and it is like sort of mirroring the contraction. It is thought this happens due to head compression. When the baby's head is compressed, especially in the late labor or when it is going into the pelvis, the intracranial pressure goes up, and therefore that stimulates the parasympathetic centers and the vagal nerve, and therefore that causes the depression of the heartbeat. But what happens is, when the contraction ends, that compression is lifted off, and at the same time the sympathetic nervous system, because heart rate goes down, the sympathetic gets activated. Ade, make a pahalata yana, make a usanno. So then it with the contraction, then it goes up. You all understand? So that is how an early deceleration takes. Early decelerations are normally not, they are not classified as being any problem, right? So if early deceleration, that probably tells us that the head is getting compressed. Okay, so we don't really need to worry too much about early deceleration. However, if the that any type of deceleration is present in the antenatal period without contractions of the uterus, right, then there is a problem. Then you need to deliver. However, early deceleration in labor is not considered as a problem at all. Okay, got it? Then comes, so if you see early deceleration, you can be early deceleration, right? The head is getting compressed, so you can come up, you can say, okay, early deceleration, so you don't need to worry too much. Okay. The next is, let's talk about late decelerations. Late decelerations is the pathophysiology behind it, you need to understand. Now, see, the placenta is supplied with blood or placental perfusion, right? And then the placenta has a certain reserve. In a normal placenta, there's always a good reserve because the placenta is a lot of blood, maternal blood, and on this side, the fetal vessels are there. So there's an exchange going on. The blood doesn't mix, it's just an exchange. Okay. If the placenta is good without any problem, the placenta has a lot of reserve, right? And therefore, when the contraction happens, right, the blood, remember, the middle layer crisscrosses and the blood vessels will go in between, right, in between the middle layer. And when the contraction occurs, the blood vessels get crushed and there is no blood supply to the placenta. However, because if the placenta has a lot of blood and reserve, the exchange goes on because the baby's heartbeat is driving the blood to the placenta and out of the placenta, to the placenta. So it doesn't really matter whether the placenta is not getting blood or not, because if there's a lot of blood, good blood in the placenta, and the placenta has no problems, the baby will not feel the contraction. You understand? However, if the placenta is insufficient and the reserve is very low, when the contraction occurs, the blood supply is cut off anyway to the placenta. But because the reserve is so low, now the baby is using up the whatever is left in the placenta, and it ends quickly. And suddenly, in the middle of the contraction, there is not enough blood for the baby. And what happens? Hypoxia, and the baby's heart starts to contract. So the late deceleration, the deceleration starts late. Initially, there's none, but then after some time, the contraction, the deceleration starts. Now, after the contraction takes place and it relaxes, the blood starts coming back. But because the placenta is not very good, right, it takes more time for the placental reserve to be replenished or to fill up. And therefore, it takes more time for the baby's hypoxia to go off. And therefore, it takes more time for the baby's heartbeat to recover, right? So it starts late, the deceleration, even when the contraction is over, it takes time for the baby's heart rate to recover. So that is why it's called a late deceleration. Starts late, ends late. So it outruns the contraction. So that is why it's called a late deceleration. Is that clear, children? So there is a pathophysiology behind the late deceleration. Okay. The next is deceleration, which we have to understand, is what we call the variable deceleration. Why is it variable? It has usually does not have a huge connection with the contraction. That is why it's called variable. Of course, there may be, because it's the contraction that normally happens, but it does not exclusively have a connection to the contraction. Early sort of mirrors it. Late starts late, ends late. But the variable has a variable. It might have and might not have a connection with the contraction. That is why it's called variable. So it's a variable thing. Okay. Now let us try and understand what a variable deceleration. They are called chord compression decelerations as well. They occur when the chord is compressed. So they can be called chord compression decelerations, or they can be called variable deceleration. Now, what is the pathophysiology which you need to understand, right? The umbilical, the cord contains 3 vessels. We have 2 arteries and we have a vein. See, the baby's heart pumps out the blood. It goes into the aorta and it gets into the common iliacs. Then the common iliacs will divide into internal and external iliacs. And from the internal iliacs springs the 2 umbilical arteries, right? So when the baby's heart pumps out blood, it distributes, and it goes through the aorta, common iliacs, external and internal iliac. And from the internal iliac, the 2 umbilical arteries spring forward. And these 2 umbilical arteries carry blood to the placenta, right? And they go along the cord. So therefore, the blood to the placenta on its way goes through the umbilical arteries, right? These arterial walls are thick, right? So you have 2 arteries which are thick walls. And also the deoxygenated blood goes to the placenta through these arteries, right? At the same time, oxygenated blood comes from the placenta via a vein, single vein, and it goes on to the heart carrying oxygenated blood. So the cord has 2 thick-walled arteries and a single thin-walled vein. Okay. Now, when a contraction or when the head or any presentive part compresses the cord, the first thing that gets compressed is the thin-walled vein, not the artery. So what happens? The blood flow to oxygenated blood flow to the heart stops. So when the blood flow to the heart stops or is impaired because the umbilical vein is compressed, the heart finds, okay, less blood coming to me. And everything gets activated inside, right? You all know I'm sure you all know all the pathophysiology about the sinoatrial nodes, this and that, everything, right? So what does it do? It immediately increases the heart rate. Okay. So what happens? From the baseline, the heart rate goes up with the initial contraction or compression of the vein, umbilical vein. And then the compression goes on, and then the compression becomes complete. It crushes the arteries also. Now, no blood is going out and no blood is coming in. What happens? There is no blood going out of the system because the umbilical arteries are compressed, and there's no blood coming into the system because the vein is compressed. The system stabilizes, right? Suddenly, the system, there is no hypotension in the system. So the heart is hard, everything looks all right. And then the heart rate starts to drop. But somewhere when it drops to the baseline, the heart finds out, machan, still no blood. Now hypoxia. Okay. So the heart rate drops, bradycardia. right? When the contraction goes off, the compression becomes lifted. Okay, so when the compression gets lifted, suddenly everything starts again, right? And now blood is there, so the sympathetic works, pat. So it starts to come up again. Okay, however, there is an overdrive of the sympathetic because the hypoxic drive has brought the whole thing very much down. So the sympathetic works, but it can't stop, or like the it cannot stop exactly at the baseline. So it overshoots and goes up again. Okay, and then everything is stabilized. No, all the system is working. Then slowly the parasympathetic, this is fellow is doing too much of work. Parasympathetic work and bring the heart back to normal. What are we looking at? We are looking at an anatomy of the variable deceleration. So we have shooting up, going down, going back, shooting up a bit and coming back. So we have two shoulders for the deceleration. Okay, and a very deep, steep dip. So that is why it's called a variable deceleration. It has shoulders. Okay. Now, if you look at a variable deceleration, there are some points in which we have to consider that there is a problem. I will say these again. These are variable deceleration with concerns. For the normal variable deceleration at it compresses the cord and it goes off. So that's all, no problem. And the hearts, sympathetic and parasympathetics are working very well because it is going up, going down, doing all the everything, right? However, when the baby is not feeling good and the placenta has insufficiency and the baby is chronically sort of hypoxic, this variable decelerations will also show some problems. What are these? Number one, the shouldering disappears. So the mehema gihilla kelima pahata gilla ohuma gilla yanawa. That is something that we need to be concerned about. There's a problem there. Okay. The second thing is, in a variable deceleration, if there is variability in between, so because the sympathetic parasympathetic is playing in the middle, so there is a variability within the deceleration. So that is, but when the variability disappears, that is a concern. Okay. So disappearance of variability within the variable deceleration is a problem. Okay. The third thing is, when it gives you a W pattern, W wave, that is also a concern. That is not exactly normal. And the fourth thing is, when the variable deceleration stretches out for more than 60 seconds, that is a problem. You all understand? So there are four things that you need to look inside the variable deceleration. Have the shoulders gone out? No shouldering. Is there no variability within the deceleration? Is it a straight line? Right? Under the straight line. Is there a W wave? W wave and the next thing is it stretched for more than 60 seconds? Right? Those are the concerns that we need to have in a variable deceleration. Got it, children? Right? So when we do that, right, we are looking at a problem. So that is how you classify these variable decelerations, right? Next, so let us try to put them into reassuring, non-reassuring, and abnormal. Okay. So if there's a variable deceleration, right? I'll just bring up the chart for you, okay, which you are going to be familiar with. I got it down, so I want to show you so that you need to be familiar with that. Right, wait 1 moment. You don't need to write that, children. Right? You don't need to write it because right. Can you see my screen? Yeah. Can you see my screen?
Yeah, just but small.
Small. Right. Okay. Let's see whether I can make it. No, I can't. Right. Is it visible for you all or not visible? Not very much. Right. Let me see.
For me, sir, not visible.
Okay. For you, it is not visible. Right. So to take you into consideration now. I really don't know how to make it bigger though. Oh, wait. Right, I think I got it. Right. Can you see my screen? Yeah.
Yeah. Yes, sir, but there's a window, black window
Yeah.
in front
Wait,
of the.
wait. I know there's a window. I'm just trying to find out. Right. Does that look better?
Yes. Yes.
Yeah. Okay.
Yes.
So look at this now, children. Now look at this, right? So if you look at this chart, this is out of the nice guideline which I want you to look at, right? Say each of these features are divided into reassuring, non-reassuring, and abnormal. Okay, so look at this. We are looking at the baseline. Okay, 110 to 160 is reassuring, which we have discussed, right? This is just a sum. Non-reassuring is 100 to 109 or 161 to 180. Okay, while abnormal is below 100, which is called bradycardia, over 180 is called tachycardia. That we discussed. Okay. Second is baseline variability. 5 to 25 is normal, which means less than 5 and more than 25, there's a problem. Okay. So the problem here, how it's divided in non-reassuring and abnormal is just a time. Less than 5, right? From 30 to 50 minutes is non-reassuring, while less than 5 or more than 50 minutes is abnormal. Is that clear? Less than, more than 25 for 15 to 25 minutes is non-reassuring. More than 25 for more than 25 minutes is abnormal. Okay. And remember, sinusoidal is also abnormal. So that is very simple. Got it? Clear? Right. Now, what is important is the deceleration part. So look at this. Decelerations, if it is reassuring phrase, there is none. No decelerations means reassuring. That feature is reassuring. But early decelerations, if it is there, it doesn't really matter. Okay. So we actually are not worried because if we look at it and we find early deceleration, please don't worry because they don't come in any part in the whole thing. If there are no deceleration or even if there are deceleration, still it will be a reassuring feature. However, remember, variable decelerations with no concerning characteristics. Remember the 4 characteristics I told you? absence of shouldering, variability within the deceleration, a W wave, and a long variable deceleration, right, which is about more than 60 seconds, right, is a problem. However, if there's a variable deceleration, right, or variable deceleration that has no problems and they do not go for over 1.5 hours, 90 minutes, then still it is reassuring. You all understand now? Right? Clear? Right? There's a lot to take on board. That is why I put this on. Right? Right? So for you all to understand that. So I will just explain to you, go back and look at it again. Right? Next, let's look at the non-reassuring decelerations. What are these? If there's a variable deceleration, right, that variable decelerations that goes on and on and on and on, but there are no concerns about it. Those 4 features are absent, just a variable deceleration, typical fellow. But it continues for more than 90 minutes, then it becomes non-reassuring. Okay? Or if there is a variable, if there are variable decelerations with problems, right, in less than 50% of the contraction. So if we in the trace, if we see 10 contractions and maybe in 4 of them, that is less than 50%, if we have a variable deceleration with problems, however, that goes on for 30 minutes or more, it has to continue for 30 minutes. Just because we see it in 1 or 2, right, in 10 minutes and it disappears, then it is not a problem. If it goes on for 30 minutes, then it more than 30 minutes, it becomes non-reassuring. Okay, just understand this. Don't try to remember it, just understand it so that when you go back, right, it is not going to look so confusing to you. Okay. Next thing is, if you have variable decelerations, okay, with problems, which I told you, in almost every contraction that happens, or more than 50% of the contraction that happens, right, even for 5-10 minutes, that is a problem, non-reassuring. Okay, that also is non-reassuring. And then the next one, the 4th characteristic in a non-reassuring means, if there's a late deceleration, which I told you about, right, in more than half the contractions that you see, even for 5 to 10 minutes, then there's a problem. That is called non-reassuring. Right? Now, from non-reassuring, let's go directly to abnormal. Right? So if there are variable decelerations, right, in more than 50% of the contractions that occur, even for 5-10 minutes, that is an abnormal feature. Okay. If there are late decelerations that goes on for 30 minutes or more, that is abnormal. Which means if you see a variable late deceleration, again you are seeing a late deceleration, again you are seeing a late deceleration, and suddenly after 10 minutes it stops, no problem. However, it goes on for more than 30 minutes, then it's abnormal. Okay. And then what is the most important thing, if you see an acute bradycardia, bradycardia, go and deliver. Or CDG, if there's a single prolonged deceleration, 3 minutes, we are not recovering. That is abnormal. Go deliver. You all understand? Right? So mainly the decelerations part, don't be worried too much, right? You need to understand this, right? So just because there's a variable deceleration does not mean that the trace has a problem, right? However, it can be non-reassuring if it goes on for more than 90 minutes, right? So this is how you classify the decelerations. It's a lot to take on board, but what you have to understand is, you have to understand this graph perfectly. That is why I put it up, so that you will again go back to it. The main thing is you should understand what these statements are about. Is that clear? Right. So let's stop the share and go back to it again. Okay. So now you take each of these and put it into each of these features and put it into reassuring, or whether they are non-reassuring and whether they are abnormal, right? And then you classify the CTG into 3 parts. What are these? Normal, suspicious, and pathological, right? And normal is what? If everything is reassuring, it's not. What is suspicious? If one thing is non-reassuring, but the 2 features are reassuring, then it becomes suspicious. And what do you do about it? The ones I told you, what I told. And then the third thing is, if there's one abnormal feature or 2 non-reassuring features, it becomes pathological. And then you need to deliver. So that is how you classify CTGs in a nutshell. Right? Is that clear? So this is what I want to tell you. I'm going to quickly show you some CTGs and we'll end this session. All right. So I think I have answered all those questions. So I will share my screen again. We'll go over some. I will quickly show you the features again so that you all understand. I do not know what the CTGs are, but I'll quickly analyze them for you so that there'll be about 10-15 CTGs. I'll quickly analyze them for you so that you understand what is happening. Right, I put them in a right. Tell me whether you can see my screen. Can you see my screen? Right. Yeah. Right. But I don't know how this is going to work out. I'm just going to click on this. Can you see this trace, children? Can you see that? Your screen sharing is post, resume. No, it's not working out that way. Right, I think I have to open each one of those individually. So let's go to that. Share screen. Right. Can you see this now? I can't see all, but can you all see this now?
One screen.
Yes, sir.
That one, can you see now?
Yes, sir.
All right, okay. Right, see, now, I'll just give you the basic. Sorry, here what you are looking at is in the classification, it is what? We have normal, suspicious, pathological, right? So this is a normal CTG. Here, if you look at this from 30, can you see my cursor? Can you see my cursor?
Yes, sir.
So this is 30, this is 240, this is the heart rate there, okay? See, each of these from here, it's half a minute, half a minute. So from here to here, it is 1 centimeter. Because in the trace, you will see, here you will see the speed. You see 1 centimeter per minute. Can you see that? So it can vary from 2 centimeters per minute or 3 centimeters per minute. Here the standard side is 3 centimeters per minute. Usually they will tell you this will have the time here as to when it was did on this date at this time. So the time will go along this. So it will give us this time. Now it's this time, this time. So that is important, but the dates must be set correctly in the machine as well. From here to here is the heartbeat. It starts from 30 to 240. So each, see, from here to here it's 30 to 60. So there is 1, 2, 3. Each of these squares upward will mean 10, 40, 50, 60. Then 70, 80, 90. So each this square this way is 10 beats. Half a centimeter is half a minute. Half a centimeter here is 1 minute. So from here to here, there is 1 minute of trace. Okay. This one is, it comes from 0, the toko, from 200. So it comes as percentages, or it can be millimeters per mercury, which can also be put in here, which is not very clear, but here it's from 0 to 100%. So this actually, if you zero the contractions, this is a 40% contraction, and it has gone on for 1 square, 2 square, almost 3 square. That is 1.5 minutes. Okay. Now let's look at this trace. First of all is the baseline. Now, what is the baseline? Baseline is anything between 2 accelerations or 2 decelerations. Now, let's look at that. Let's find an acceleration. So let's have a look at this. So if the baseline is probably this, so if we look at this and this looks like an acceleration, this might be an acceleration. So the baseline, we have to take it as this. So the baseline is, this is 120, 100 and this is 100. What is this now? 120, 150 and 1 square there. So it is about 100, almost 160, but it touches here. So it's somewhere around 150. So the baseline is about 150. Okay. So is it reassuring? Yes, it is reassuring. Then let's check whether it is an acceleration. So an acceleration from the baseline, it has to go for 15 beats. So which means each of these square is 10. So it has gone 10, 20 and almost 30. And it has to go for 15 seconds. Now 15 seconds is half of this half centimeter. But this acceleration has gone from here to here, which is half a minute, 30 seconds. So definitely this is an acceleration. You all understand? However, if we look at this, if the baseline is here, it has gone 10, but not 20, maybe 15, but yes. So this also has gone on for about 15 seconds. So it has gone 15 above and 15 seconds. So this is also can be considered as an acceleration, right? So these are the accelerations. So there are accelerations, and how do you calculate the baseline variable? So if you take 2 accelerations here and you consider this as the baseline, so we take 1 minute here from here to here, and we take the highest point and the lowest point within that 1 minute. This is the highest point and this is the lowest point. So what is the difference? 10 and almost 10 there. So 20. So baseline variability is 20, right? And therefore, we have a baseline of about 150. We have accelerations. We have a baseline variability of about 20, right? And no decelerations. So this is a perfectly normal trace because all the features are reassuring, right? You all understand that, right? Got it? So I just analyze a normal trace for you all, right? Do I have to explain that anymore? No, right? So let me just get something pathological for you, and then we will stop the right. Right, can you see my screen here? Can you someone say, because I can't see?
Yes, sir, we can see.
Right. Okay, children. Now, if you look at this, see the baseline is, say this is 100, this is 120, right? This is 140. So the baseline is somewhere about 142. Is that clear? So this is looks like the deceleration, and this is definitely a deceleration. But this is the baseline. So the baseline is 140. Okay, which is what? Which is reassuring. Okay, then the baseline variability. So the most amount of variability seems to be here or here. So we will choose 1 centimeter, that is 2 squares, right? From here to here. So the highest point here is this, the lowest point seems to be here. So each square is 10. So about 10, about 20. So the baseline variable is 20. Is that reassuring? Please talk, because I can't see y'all.
Yes, sir,
Yes.
it's reassuring.
Okay, it is reassuring. So 2 of the features are reassuring. Okay. Now let's look at the decelerations. So deceleration here, look, this is not a deceleration. Why? Because it is very thin. So it has not gone for 15 seconds. 15 seconds is what? It has to go about at least half the square of this. Half of this. Because from here to here, it is 30 seconds. From here to here, it is 30 seconds. This is 1 minute. So this one is very thin. Again, it's not actually deceleration, it's just a variability of the fetal heartbeat. So, but here you can see it has started to go down, right? So what is the dip? If this is 140 is the baseline, now you have 10, 20, 30, 40, 50, 60, 70, 80, 90, 20. So can you see it has gone down to about 40. From 140, it has gone down to 40. So definitely more than 15 beats. How long has it gone? This is half a minute. This is 1 minute. So it has gone for about slightly more than 1 minute, right? So this is definitely a deceleration. Now let's see what type of deceleration is it. For that, we have to check the contractions, okay? So here, you see there's one contraction, another contraction, and this seems to be another contraction. So let's see, when the contraction seems to have started here. So if you draw a line here, you can see that the deceleration has not started yet. Clear? When it goes somewhere here, the deceleration seems to have started. Then here the contraction has stopped, but the deceleration has gone on. So what does it make this deceleration?
Late deceleration.
Excellent, child, excellent, right? But remember, even if these late decelerations go on for 30 minutes or more, then only it becomes what? A abnormal feature, and therefore it becomes a pathological CTG. So here we have just a single late deceleration. However, here we have a normal baseline and a normal baseline variability with a single late deceleration. Are we worried yet? No. But here we have to continue this CTG for 30 minutes or so, and still, if the late deceleration starts occurring at least in half of the contractions or more than half, then we are worried. Okay, then it becomes an abnormal feature, and therefore one abnormal feature would mean that it is pathological CTG. So it is not enough for us to judge whether it is pathological at this moment. Okay, got it? Right. So then I will show you something else, right? Let me just check. Just wanted to show you. Okay. Okay, now this doesn't look good, right. So I will show this to you. Right. Can you see this? Can you see this, children?
Yes, sir.
Right. Now look at this. How do I make it bigger? I actually don't know. But can you see this? Right? So look at this. Is it actually the other way around? Yeah,
Upside down.
upside down. And I really don't know how to make it. Okay, rotate. Rotate now. Okay. Now I'm happy. Now look at this, children. I wish I can make this more bigger. Yeah. I am really getting good at this. Can you see that now? Now I am also happy. Right. Look, children, if you look at this CTG, now this is the baseline. Can you see that? Anything between two decelerations is the baseline. Can you see this baseline now? The baseline is at, we'll make it bigger. Oh, so the baseline is at 140. Can you see that? Right? So is it reassuring? Yes. So that feature is reassuring. Right. Then let's look at the baseline variability. Anything in between two decelerations or acceleration is the baseline variability. But can you see what has happened? If you take one square here, this is 1 minute, right? And you take the top and the bottom of the troughs and end, it's about 2 beats. It's hardly going in, it's almost flat. So what is the variability like? Here, the variability is not very good. However, if you look at the best part, let's look at this part. Okay. So if you take 1 minute, this is the peak and this is the lowest peak. See, one of these squares is 10. So actually, the variability is about 10 here. Can you see that? So is it reassuring? Yes. Right? Even here, look at this part, because we take the best part. If you take this part, this is 1 minute, right? This is the highest, this is the lowest. And it is more than sort of 1 square. So this is also about 12. Is it good? It's reassuring. So the baseline is normal and the baseline variability is also reassuring. Okay? Right. So the two of the features are reassuring here. Now let's look at the other feature. What are we looking at? Right? We are looking at decelerations. Okay? Now let's look at this deceleration. See, there's a contraction here. The contraction sort of starts slowly here, but it comes here and then contractions goes down. But look at the deceleration. It starts here. So it starts late. Got it? The contraction starts, but it sort of starts late. It dips down. So is it a deceleration? Yes, because it goes down 10, 20, 30, 40, 50, 60, 70 beats. And for how long does it go? 1 minute, 2 minutes, 3 minutes, and almost 3.5 minutes. What is it? It's a prolonged deceleration, right? And where does our prolonged deceleration come? It's an abnormal feature. So we have one abnormal feature in the whole CTG with 2 reassuring features, but one abnormal feature in the CTG will make it what? A pathological CTG. You all understand? So if we have one, now let's look at this one. Almost 1 minute here and 2 minutes here. That is not a prolonged deceleration, but it is still a deceleration. Look at this deceleration. Starts sort of here, 1, 2, and almost 3. This is also prolonged deceleration. So continuously, we are looking at prolonged deceleration. This fetus needs to be delivered. Okay, so that is right. So I think we have looked at enough CTGs. Do you want me to look at anything more? Do you want more CTGs?
Yeah.
Yes, the thirst for knowledge. Right, let me see if there are any interesting ones. Just looking at them, okay? Ayyo. No, I didn't have any more interesting ones, not very sort of. Right. So, what I want you to understand now is that I have discussed with you in summary the pathophysiology, the physics behind it, right? And you have to understand that we look at only 4 features in the CTG, right? Initially, please, when you are doing CTGs, write the name of the patient if it is not printed, the time you started if the machine is not printing the time, right? Check whether it is going at 1 centimeter per minute, because if it is 3 centimeters per minute, it will look a bit funny because it's all drawn out and our eyes are not used to that, right? But in other countries, USA, they use 3 centimeters per minute. It goes very quickly, right? So therefore, there's a change. So look at the speed as well, right? And then you have to, usually there is, you have to write about 4 things. You're right, when you look at the CTG, right? When you stop the CTG, just draw a line and then you stop the CTG and then you analyze that part, right? And you need to sign there. So what are the things you look for? The baseline variability, presence of accelerations and decelerations, right? And the decelerations, you have to classify it to whether it is a whether it's an early deceleration, whether it is a late deceleration, or whether it is a variable deceleration. If it is a variable deceleration, you need to check whether there are any concerns in that, which are 4. Absence of variability within the deceleration, whether it is going for more than 60 seconds, whether there is a W wave inside the delay, and whether there is absence of shouldering. Right? So those are the things that has concern. So variable deceleration with concerns. Okay. So once you have analyzed all that, then you go on to find out or classify these, right, into normal, suspicious, or pathological. Normal is all features are reassuring. Suspicious is one feature is non-reassuring, while 2 features are normal. Abnormal is either there's pathological means if there's 1 abnormal feature or 2 non-reassuring features, or if there's 1 abnormal, it becomes pathological. If there are 2 non-reassuring, it becomes pathological. You all understand? So that is very easy. So CTG made easy for you all. Then what you go is, go to that table and look at it again, right? And get that into your brain, because now you all should understand it. And then from here onwards, you'll be top class CTG interpreters. So you can give a call to your seniors and say, hello, yes, there is a pathological CTG. Please come and see. Okay. So that is all which I wanted to tell you all today. So let's see. What's the duration of a prolonged deceleration? 3 minutes. 3 minutes. If it continues for 3 minutes, then prolonged deceleration. Prolonged deceleration, the feature is abnormal. That automatically makes it pathological CTG classification. Okay. Right. So looks like we have no more questions. Okay. So shall we stop?
Yes, sir.
Adine? Other Adine? Right. Okay then. Okay. Good night.
Thank you, sir.